segueing to your dissertation, so you
Yeah.
mentioned that that is in the respiratory realm.
Hmm.
Can you talk a little bit about what you're doing with that?
Yeah, yeah. So, obesity and morbid obesity or class two obesity, depending on whatever definition we're using nowadays. I'm working with patients undergoing bariatric surgery, so weight loss surgery. And again, which I think is a fascinating population for a lot of reasons. And I think that's an area of practice, one that PTs should probably be more involved in, just because of some of the unique needs they have and skills that we can provide to address those needs. But in obesity, we find respiratory muscle weakness for a lot of different reasons. One, we see a lower, so at the end of expiration, right, there is a little bit of air remaining in your lungs. You don't fully collapse your lungs when you breathe out, right? There's always a little bit of air remaining. In obesity, because of the higher truncal fat, we alter the force couple relationships between the outward pull of the chest wall and the inward pull of the lungs. We basically reduce the outward pull because there's more fat in the trunk and abdomen, which creates a net greater increase pulling towards the lungs. So basically, there's less air in the lungs in an obese individual. They have lower volumes generally. And lower volume specifically at the end of expiration. When you have less air in your lungs, the caliper size of your airways gets smaller, which increases airway resistance. So they have to work a little bit harder to generate, enough pressure to bring air into the lungs, basically. Okay. The other side is we find that if they have, again, a larger abdomen because of the additional adipose tissue, that can potentially impair the length tension relationship of the respiratory muscles. Like they may not be able to generate enough force because there's just more stuff basically in the way. The other side is we're finding that there may be changes to expiratory flow or basically the smaller airways are smaller, and there may be higher resistance in the larger airways too, for a lot of different reasons. Maybe inflammatory changes, airway reactivity changes, and we think, are you guys familiar with adipokines or myokines or like the factors? So your adipose tissue is a very active tissue, right? It releases these factors that have autocrine, endocrine, and paracrine functions. So autocrine, they can act upon themselves. Paracrine, they can act on tissues neighboring to them. And an endocrine, if they get into the bloodstream, they can affect tissue everywhere, right? And pretty much every substance in our body is kind of muscles that way too. Myokines, you all know those, right? But adipokines, or some of them can be pro-inflammatory, especially in the state of obesity, where there's too many of them, too much obesity, too much white adipose tissue, and they have very deleterious effects on blood vessel function, and muscle function, affecting contractile properties. We also see changes to IGF-1, myostatin, which can affect the hypertrophic response to exercise, to training. So we see lower testosterone too in obesity as well. So not only do patients with obesity have higher demand because of those smaller airways, higher airway resistance, the muscles may be affected intrinsically and extrinsically. So their force generating capacity is lower and their demand is a little bit higher, which may explain why during exercise or even minimal activity, they get short of breath a lot earlier than a healthier individual or leaner individual. So problem is, like, there's a lot more obese people, right? We want them to exercise, but if you get short of breath from like walking 2 blocks, like how effective is exercise going to be for you as a solution? And for weight loss, resistance training, like which doesn't have as high of inventory demands, probably not as effective. It'll be effective to a degree, but we want them engaging in more long-term, continuous aerobic work if possible, or maybe interval work. But either way, just getting them going can be kind of challenging. We also see some changes during responses to exercise as well. So basically what my study is doing is we're looking at how those breathing muscles are affected, looking how inflammation may affect that, because we've identified this relationship between inflammation and respiratory muscle performance in patients with sepsis and patients with heart failure, COPD, and in mouse models of obesity and diabetes. We haven't done it in a human model. So this is my study may answer some questions along that line. And they were looking at how respiratory muscle training using one of these devices here, which is a little pressure device, pressure threshold device, how that will improve it, how that may affect their responses to exercise, and tolerance, or their perceived perceptions of dyspnea, as well as post-operative complications. Obese individuals are harder to wean after mechanical ventilation, which you're on during surgery. So we were seeing that offsets that risk a little bit too. So it's a pretty ambitious project for a dissertation, but go big or go home, I guess. So yeah, I don't know if that was way too wild or not.
No,
but,
that was great.
Yeah,
respiratory muscle training, and going back to some of the myths potentially, where it's all about the diaphragm, and in fact, we can even assess the function of your left and right crura and the left and right side. I'm not saying these are the kind of the things that we hear.
Oh,
and
that's a new one.
When your left diaphragm is probably inhibited right now, Rich. You just don't know it because you haven't been into my office yet. But
it's funny. There was a paper that was published in JOSPT back in 2013. Nate Hillier was on that paper. We did a talk together at CSM 2017. And there are patients sometimes who are completely asymptomatic at rest who have a hemodiaphragm. Half their diaphragm doesn't work.
Really?
Yeah.
Can you?
He assessed B mode ultrasound and M mode ultrasound, looking at diaphragmatic movement, trying to get some normative values or like what that is with ultrasound. And he was asymptomatic patients, and there are a couple patients in his sample that were had no pulmonary disease, no symptoms, and one hemodiaphragm diaphragm didn't move at all.
Whoa!
And they found that diaphragm motion in healthy individuals is variable. That's a PT, as open access. So it's like you don't have to make these things up. It's like it's there. Yeah.
Well, I don't want to dive down that rabbit hole too far, but we could take that a few different ways, because there may be some people listening now that are like, see,
gotcha.
Hemidiaphragm paralysis. So that's something we can do about. Where maybe the other flip side is perhaps it's just normal human variability. We just don't know because we haven't really found those base rates. It could, I don't know. What are your thoughts on that?
The evidence suggests that patterns of breathing are very, very variable and across a human population. That's why I'm not super big on feeling, touch like that. What are you doing there, right? You're wasting time. And if it works for them, if you don't have blood gas changes, which probably not going to happen in a healthy individual for a lot of reasons, probably fine, right? Two, the hemodiaphragm in that example, just shows that it's probably a lot more complicated than we realize. And that was assessed using ultrasound. That wasn't assessed by arbitrarily feeling your hands. How can you can't see the respiratory muscles, right? You can't see them without visualizing them with an ultrasound or fluoroscope. So I don't know what people are claiming to do with these other assessments, but
would you be able to feel inflation differences if you had a left hemidiaphragm or a right hemidiaphragm? That was, you think? Maybe.
But again, that person was walking around and didn't even know it, I think.
Yeah.
So and I think, and there's another case study that was published a couple years ago by Cahalan, with a rugby player who sustained a neck injury, and he was asymptomatic, but as he continued on and got older and was still continuing to exercise, started noticing that he had breathlessness, and they found actually he had a hemidiaphragm. Only one worked. So it's probably individualized, but again, if you unless you don't stress the system to a certain point, you're probably not going to notice. And there are some conditions like post polio where we see changes potentially the respiratory muscles. We see like what we call paradoxical movement, like your chest wall and your abdomen don't move in sync. So your abdomen and chest wall should move together. But these are rare examples, and we haven't had polio in the United States in 50 years, right? 50 years, something like that. So, yeah, I don't know if that answered the question or not, but yeah,
totally. So go ahead, John.
And just to repeat, there was ultrasound used to make these assessments, not putting your hands on somebody's stomach or watching them breathe. This isn't something that you can just kind of clinically do nonchalantly.
Yeah, and we can do ultrasound too. Like we can, right? Like that's something that blows my mind. Like, John brought up a good point. That, like, you can't just feel these things, right? Like it's probably not going to be as effective as looking at them. And PTs can do ultrasound or can do neuromuscular ultrasound. We do it for the TA, right? That's a big thing now, right? With like making sure you're bracing, all these other things. And we do it for in a cross-sectional area for muscle function. People are doing it now for dry needling, right? They're doing like ultrasound guided dry needling. Just move that ultrasound probe a little bit further up, 7th or 8th intercostal space. You're good to go. It's real simple. And I actually have a call after our podcast, a guy from England, Simon Hayward. We're hoping to kind of bring a course here to train PTs on how to do it. So super easy to do.